Hello, this is Emergency Care and Transportation of the Sick and Injured, Chapter 9, Patient Assessment. In this unit, you'll be able to understand the scope and sequence of patient assessment for medical and trauma patients and all the phases and components of patient assessment. Please note that this chapter is divided into 5 sections: scene size up, primary assessment, history taking, secondary assessment, and reassessment. These divisions will help facilitate the instructor's approach, or my approach, for teaching this skill as a whole concept. The importance of patient assessment cannot be overemphasized. EMTs must master and be comfortable with patient assessment process. Patient assessment is used to some degree in every patient encounter. The assessment process is divided into 5 main parts: scene size up, primary assessment, history taking, secondary assessment, and reassessment. The order in which the steps are performed depends on the patient's condition and the environment in which the patient is found. It may be necessary to change the order of some of the steps after scene size up based on your findings and the need to prioritize the care of certain conditions. Rarely does one sign or symptom show you the patient's status or underlying problem. A symptom is a subjective condition that the patient feels and tells you about. A sign is an objective condition that you can observe or measure about the patient. The treatment of EMTs provide patient is based on symptoms, not an exact diagnosis. The patient assessment process is the foundation upon which all levels of EMT are built and is the starting point for all patient care. Let's discuss scene size up. The scene size up refers to your evaluation of the conditions in which you will be operating. Situational awareness is necessary throughout the entire call to ensure safety. Situational awareness is paying attention to the conditions and people around you at all times and the potential risk of those conditions or people pose. Scene size up is the first thing to consider, but it does not end as providers move through the assessment process. Dispatch provides basic information about the request for assistance. Scene size up information and observations are there to help ensure safe and effective operations. An understanding of the situation and conditions prior to responding, the dispatcher's information, and then observation of the scene. You must ensure scene safety. Issues that you may encounter in the pre-hospital setting can range from minor difficulties to major dangers. Even scenes that first appear relatively safe and secure can turn unsafe with little notice. If a scene is not safe for you and your team to enter the scene and approach to manage the patient, do what you can to make it safe or call for additional resources such as firefighters, utility workers, hazardous materials technicians, or law enforcement personnel. Typically, the way you enter an area is also the way you will leave, with a stretcher, a patient care equipment, and personnel belongings. Make sure to consider difficult terrain. Consider traffic safety issues and issues related to scene safety if you must approach a patient on a working roadway, where at a minimum a high visibility Class 2 or 3 safety vest approved by the American National Standards Institute. Other traffic incident management techniques may be appropriate, such as personnel, traffic markers like cones, flares, and signs, and strategic positioning of emergency vehicles. Consider environmental conditions at the scene. Your patient may be outdoors, indoors, or in a public place. Be aware of the weather and physical terrain. Working in unfavorable conditions and on unstable surfaces is a large part of pre-hospital care. A good rule to use when faced with a wide variety of possibilities is that any actions you may take to protect yourself should also be considered for the patient. If appropriate, help protect bystanders from becoming patients as well. Some forms of hazards include environmental, physical, like sharp metal, broken glass, or slip and fall hazards, chemical, which is hazardous materials, electrical, water, fire, explosions, or physical violence. Be aware of scenes that have the potential for violence. You may have violent patients, distraught family members, angry bystanders, gangs, or unruly crowds. An emergency scene is a dynamically changing environment. It is up to you to either make the scene safe if you have the training and equipment to safely do so, or call for additional resources and move to a safe location. Determining mechanism of injury, which is called MOI, or nature of illness, which is called NOI. Virtually all calls for assistance to which you may respond can be categorized as medical conditions, traumatic injuries, or both. A medical problem can lead to a traumatic injury. You will need to be able to identify the general classification and underlying issues of the emergency or emergencies to which you respond. Traumatic injuries are the result of physical forces applied to the outside of the body, usually from an object striking the body or the body striking an object. They're classified according to the type or amount of force, how long it was applied, and where it was applied to the body. This is described as the mechanism of injury, or MOI. Certain parts of the body are more easily injured than others. Fragile and easily injured areas include the brain, spinal cord, and eyes. An understanding of anatomy and physiology will help EMTs to identify times when a mechanism of injury may lead to injury to parts of the body not directly impacted. With blunt trauma, the force of the injury occurs over a broad area and the skin is sometimes not broken. However, the tissues and organs underneath the area of impact may be damaged. With penetrating trauma, the force of the injury occurs at a specific point of contact between the skin and the object. It is an open wound with high potential for infection. For medical patients, determine the nature of illness, or NOI. There are similarities between the MOI and the NOI. Both require you to search for clues regarding how the incident occurred. To quickly determine the NOI, talk with the patient, family, or bystanders. Use your senses to check the scene for clues as to the possible problem. Be aware of scenes with multiple patients who are exhibiting similar signs or symptoms. This could indicate an unsafe scene for you and your partner as well. Considering the MOI or NOI early can be of value in preparing you to care for your patient. During your pre-hospital assessment, you may be tempted to categorize your patient immediately as a trauma or medical patient. But remember, the fundamentals of a good patient assessment are the same despite the unique aspects of trauma and medical care. Take standard precautions. Standard precautions and personnel protective equipment, PPE, need to be considered and adapted to the pre-hospital task at hand. PPE includes specialized equipment that provides protection to the wearer. The type of PPE will depend on the specific job duties required during patient care interaction. Standard precautions are protective measures that have traditionally been recommended by the Centers for Disease Control and Prevention for use in dealing with objects, blood, body fluids, or other potential exposure risks of communicable disease. The concept of standard precaution assumes that all blood, body fluids, except sweat, non-intact skin, and mucous membranes may pose a substantial risk of infection. This includes blood and other potentially infectious materials that are dried because some diseases can live outside of the body for days. When you step out of the EMS vehicle and before the actual patient contact, standard precautions must have been taken or initiated. At a minimum, gloves must be in place before any patient contact. Also consider glasses and a mask. If the patient's condition warrants a higher level of PPE, providers should regroup and upgrade the protection. During scene size-up, it is important to accurately identify the total number of patients. This is critical in determining your need for additional resources. When there are multiple patients, you should use the incident command system, Identify the number of patients and then begin triage. The Incident Command System is a flexible system implemented to manage a variety of emergency scenes, and triage is the process of sorting patients based on the severity of each person's condition. Consider additional or specialized resources. Some situations may require more ambulances and specialized resources. Specialized resources include advanced life support, ALS, air medical support, fire departments who may handle hazardous materials management, technical rescue services, including complex extrication from motor vehicle crashes, wilderness search and rescue, high-angle rope rescue, or water rescue. Law enforcement personnel may be needed to assist with traffic or scene control and should be first to enter crime scenes and hostile environments. To determine if you require additional resources, ask yourself, does the scene pose a threat to you, your patient, or others? How many patients are there? Do you have the resources to respond to their conditions? Patient assessment begins when you greet your patient. The single all-important goal of the primary assessment is to identify and begin treatment of immediate or imminent life threats. You must physically examine the patient and assess level of consciousness, which is LOC, and airway, breathing, and circulation, which is ABCs. Form a general impression. The initial general impression is formed to determine the priority of care and is the first part of your primary assessment. This includes making notes of the person's age, sex, race, level of distress, and overall appearance. As you approach, make sure the patient sees you coming. Note the patient's position and whether the patient is moving or still. Avoid standing over the patient if possible. Address the patient by name. Introduce yourself to the patient. Ask about the chief complaint. The patient's response can give you insight into the LOC, air patency, respiratory status, and overall circulatory status. Make sure to address life threats immediately. Define whether your patient's condition is stable, stable but potentially unstable, or unstable to direct further assessment and treatment. The LOC can tell you a great deal about the patient's neurologic and physiologic status. Determine which of the following categories best fit your patient: unconscious, conscious with an altered LOC, or conscious with an unaltered LOC. Assessment of an unconscious patient focuses first on airway, breathing, and circulation, ABCs. Sustained unconsciousness should warn you that a critical respiratory, circulatory, or central nervous system problem or deficit might exist. If someone is conscious with an altered LOC, it may be due to inadequate perfusion. Perfusion is the circulation or blood within an organ or tissue. It can also be caused by medications, drugs, alcohol, or poisoning. To assess for responsiveness, use the mnemonic AVPU or AVPU and choose one description. A is awake and alert, where the patient is awake and aware of you and responsive to the environment. Responsive to verbal stimuli. The patient is not alert and awake. The patient's eyes open to loud verbal stimuli, and he or she is able to respond in some meaningful way when spoken to. Responsive to pain, that's your P. The patient does not respond to your questions but moves or cries out in response to painful stimulus. And U is unresponsive, so the patient does not respond spontaneously or to verbal or painful stimulus and has no cough or gag reflex. So it's A for awake and alert, V is responsive to verbal stimuli, P is responsive to pain, and U is unresponsive. AVPU. Test responsiveness to painful stimuli. Stimulus tests determine whether a patient who does not respond to verbal stimuli will respond to a painful stimulus. These tests include pinching the patient's skin in the back of the upper arm or in the trapezius area. You can also press down on the bone above the eye. Applying upward pressure along the ridge of the orbital rim along the underside of the eyebrow. A patient who moans or withdraws is responding to the stimulus. Orientation tests mental status by checking a patient's memory and thinking ability. This evaluates a patient's ability to remember person, he remembers his or her name, place identifies the current location, time, the current year, month, and approximate date, an event where they can describe what happened. Evaluate long-term memory, intermediate-term memory, and short-term memory. If the patient knows these facts, the patient is said to be alert and fully oriented. Alert and oriented to person, place, time, and event, or alert and oriented times 4. In other words, they know person, place, time, and event. That's oriented times 4. Any deviation from alert and oriented to place, time, and event, or from a patient's normal baseline is considered an altered mental status. Identify and treat life threats. A life-threatening condition can quickly lead to death. Conditions that cause sudden death are airway obstruction, respiratory failure, respiratory arrest, shock, severe bleeding, or primary cardiac arrest. In most cases, identifying and correcting life-threatening issues begins with the airway, followed by breathing and circulation, ABC. When a patient is in cardiac arrest, the ABC should be simultaneously to minimize the time to first compression. When a patient has a life-threatening bleeding, it is more appropriate to address life threats to circulation first, following a sequence of circulation, airway, and breathing. That is CAB. Assess the airway. As you move through the primary assessment, stay alert for signs of airway obstruction. To prevent death or permanent disability to your patient, you must ensure that the airway remains open or patent and adequate. With responsive patients, patients of any age who are talking or crying have an open airway. Watching and listening to how patients speak may provide important clues about the adequacy of their airway and the status of their breathing. If you identify an airway problem, stop the assessment process and work to clear the patient's airway. With unresponsive patients or has a decreased LOC, immediately assess the patency of the airway. If there's a potential for trauma, use the jaw thrust maneuver to open the airway. If you cannot obtain a patent airway using the jaw thrust maneuver, or if it can be confirmed the patient didn't experience a traumatic event, use the head tilt chin lift maneuver to open and maintain a patent airway. Another cause of airway obstruction in an unconscious patient could be relaxation of the tongue muscles, allowing the tongue to fall into the back of the throat. Signs of obstruction in an unconscious patient can be obvious trauma, blood, or other obstructions. Noisy breathing such as snoring, bubbling, gurgling, crying, stridor, or other abnormal sounds. Extremely shallow or absent breathing is also an alert sign. Once you have made sure the patient's airway is open, make sure the patient's breathing is present and adequate. A patient who is breathing without assistance is said to have spontaneous respirations or spontaneous breathing. As you assess the patient's breathing, ask the following questions. Is the patient breathing? Is the patient breathing adequately? And is the patient hypoxic? Consider positive pressure ventilations that should be performed for patients who are not breathing or whose breathing is too shallow or too slow. If the patient is breathing adequately but remains hypoxic, administer oxygen. The goal for oxygenation for most patients is an oxygen saturation of approximately 94 to 99%. If a patient seems to develop difficulty breathing after your primary assessment, you should immediately reevaluate the airway. Consider providing positive pressure ventilations with an airway adjunct when respirations exceed 28 breaths per minute, respirations are fewer than 8 breaths per minute, or respirations are too shallow to provide adequate air exchange. Shallow respirations can be identified by little movement of the chest wall, which is reduced tidal volume, or poor chest excursion. Observe how much effort is required for the patient to breathe. If there's presence of retractions, use of accessory muscles, nasal flaring, 2 to 3 word dyspnea, tripod position, sniffing position, or labored breathing. Respiratory distress occurs when a person, particularly a child, has difficulty breathing. It's an increased effort and rate. Respiratory failure occurs when the blood is inadequately oxygenated or ventilation is inadequate to meet the oxygen demands of the body. The ultimate result of respiratory failure, if it is not corrected, is, of course, death or disability. Assess circulation. This will help you assess their mental status, their pulse, and the skin condition. When assessing pulse, it's often referred to as a heartbeat, and this is the pulse as the pressure wave that occurs as each heartbeat causes a surge in the blood circulating through the arteries. To determine if a pulse is present, you will need to palpate or feel the pulse. In responsive patients who are older than 1 year, you should palpate the radial pulse at the wrist. In unresponsive patients older than 1 year, you should palpate the carotid pulse in the neck. Palpate the brachial pulse located in the medial area or the inside of the upper arm in children younger than 1 year. If you cannot palpate a pulse in an unresponsive patient, begin CPR. If an AED is available, turn it on and follow the voice prompts, following your local protocol. If the patient has a pulse but is not breathing, provide ventilations at a rate of 10 to 12 breaths per minute for adults and 12 to 20 breaths per minute for an infant or child. Monitor the patient's pulse. If the patient becomes pulseless, start CPR and apply the AED. With skin condition, perfusion is assessed by evaluation of a patient's skin color, temperature, moisture, and capillary refill. A normally functioning circulatory system perfuses the skin with oxygenated blood. The skin's color is determined by the blood circulating through the vessels and the amount and type of pigment that's present in the skin. Poor peripheral circulation will cause the skin to appear pale, white, ashen, or gray. When blood is not properly saturated with oxygen, it appears blue. High blood pressure may cause the skin to become abnormally flushed and red. Changes in skin color may also result from chronic illness. Skin temperature. Normal skin temperature will warm to the touch. Normal body temperature is 98.6 degrees. Abnormal skin temperatures are hot, cool, clammy, and cold. With skin moisture, dry skin is normal, and skin that's wet, moist, or often called diaphoretic, or excessively dry and hot suggests a problem. Capillary refill is often evaluated in pediatric patients to assess the ability of the circulatory system to perfuse the capillary system in the fingers and toes. Capillary refill time can be affected by the patient's age, history, medications, and the environment. To test capillary refill, place your thumb on the patient's fingernail with your fingers on the underside of the patient's finger and gently compress. Remove the pressure. As the underlying side of the capillaries refill with blood, the nail bed returns to its normal pink color. With adequate perfusion, the color in an infant's or child's nail bed should be restored to its normal pink color within 2 seconds. This is an example of how to test for capillary refill, as I just suggested. Assess and control external bleeding in trauma patients. In trauma patients, identify and control major external bleeding. This step should occur before addressing airway or breathing concerns. Bleeding from a large vein is characterized by a steady flow of blood, whereas bleeding from an artery is characterized by a spurting flow of blood. Run your gloved hands from a patient's head to toe, pausing periodically to see if your gloves are bloody. Controlling external bleeding is often very simple. Just apply direct pressure, and if direct pressure is not quickly successful, or if there's an obvious arterial hemorrhage of an extremity, apply a tourniquet and follow your protocols for tourniquet use. Perform a rapid scan to identify life threats. Scan the patient's body to identify injuries that must be managed or protected before the patient is transported. Take 60 to 90 seconds to perform the rapid scan. This is not a systematic or focused physical examination. That will be performed during the secondary assessment, and this will be reviewed in Skills 9-1. The primary assessment assists in determining transport priority. High priority patients include those with any of the following conditions: patients who are unresponsive, give poor general impression, or difficulty breathing. Also, patients with uncontrolled bleeding, responsive but unable to follow commands, severe chest pain, pale skin or other signs of poor perfusion, complicated childbirth, or severe pain in any area of the body. If a spinal injury is suspected or found on assessment, consider spinal immobilization. The golden hour, what is called the golden period, is the time from injury to definitive care, which during treatment of shock and traumatic injuries should occur because survival potential is best. Aim to assess, stabilize patient and package and begin to transport to the appropriate facility within 10 minutes. This is often referred to as the Platinum 10 after arriving on scene. The illustration on this slide represents the golden hour, or the golden period. Transport decisions should be made at this point. Some patients will benefit from immediate transport while others are better served on scene. Transport decisions are based on the patient's condition, availability of advanced care, distance of transport, and local protocols. History taking provides detail about the patient's chief complaint and an account of the patient's signs and symptoms. It also includes demographic information. Be sure to document the following information: the date of the incident, the patient's age, patient's gender, race, past medical history, and patient's current health status. Investigate the chief complaint or history of present illness. To investigate the chief complaint, begin by making introductions, make the patient feel comfortable, and obtain permission to treat. Ask a few simple and direct questions. Refer to the patient as Mr., Miss, or Mrs. using the patient's last name. Ask open-ended questions, and this will help determine the chief complaint. Use eye contact to encourage the patient to continue speaking and repeat statements back to show understanding. If the patient is unresponsive, information about the patient, persistent past medical history, and clues about the immediate incident may be obtained from family members who are present, a person who may have witnessed the situation, bystanders, medical alert jewelry, or other patient medical history documentation. Using the OPQRST mnemonic for gathering additional information about the patient's present illness and current symptoms are: O, which is onset. What were you doing when symptoms began? P is provocation or palliation. Does anything make the symptoms better or worse? Q is quality. What does the symptom feel like? R is region or radiation. Where do you feel the symptoms, and does it move anywhere? Severity, on a scale of 0 to 10, how would you rate your symptoms? T is timing. Has the symptom been constant, or does it come and go? Identify pertinent negatives. Pertinent negatives are negative findings that warrant no care or intervention. Pertinent negatives are often helpful in identifying a patient's problem and choosing an appropriate treatment. Obtaining a sample history. Symptoms are complaints that cannot be felt or observed by others. Signs are objective conditions that can be seen, heard, felt, smelled, measured by you or others. Using the mnemonic sample to obtain the following information. S is signs and symptoms. What signs and symptoms occurred at the onset of incident? A are allergies. Is the patient allergic to any medication, food, or other substance? M is medications. What medications is the patient prescribed? P is pertinent past medical history. Does the patient have any history of medical, surgical, or trauma occurrences? L is last oral intake. When did the patient last eat or drink? And E is events leading up to the injury or illness. What key events led up to this incident? Critical thinking in assessment is an essential component in assessing a patient. It involves gathering, which is seeking facts to help your clinical decision making and scene management. E is evaluating, considering what the information gathered means, and then synthesizing, which is putting together the information you've gathered and validated and synthesizing it into a plan to manage the scene and or care for the patient. Take history on sensitive topics, alcohol and drugs. Signs may be confusing, hidden, or disguised. Many patients may deny having any problems. History gathered from a chemically dependent patient may be unreliable. Do not judge the patient and be professional in your approach. Physical abuse or violence. Report all physical abuse or domestic violence to the appropriate authorities. Follow state laws and local protocols. Do not accuse. Instead, immediately involve law enforcement. With sexual history, consider all female patients of childbearing age who report lower abdominal pain to be pregnant unless ruled out by history or other information. Questions to ask when faced with this pre-hospital scenario are: A, when was your last menstrual period? B, are your periods normal? C, if the patient is bleeding, how many sanitary pads or tampons have you used? D, do you have urinary frequency or burning? What is the severity of cramping, and are there any foul odors? Are you sexually active? Is there a possibility you may be pregnant? Are you taking birth control pills? Ask about urinary symptoms with male patients. Is there pain associated with urination? Do you have any discharge, sores, or an increase in urination? Do you have burning or difficulty voiding? Has there been any trauma? Have you had recent sexual encounters? When appropriate, ask about the potential for sexually transmitted diseases in all patients. Special challenges in obtaining patient history include silence. The patience is extremely important when dealing with patients in their emergency crisis. Using closed-ended question that requires a simple yes or no answer may work best. And consider whether the silence is a clue to the patient's chief complaint. Overly talkative. Gathering details about a patient's medical condition may be difficult if he or she talks around your question or you have a difficult time refocusing the patient's conversation. Reasons why a patient may be overly talkative are excessive caffeine consumption, nervousness, ingestion of cocaine, crack, or methamphetamines, or some kind of underlying psychological issue. With multiple symptoms, this is often true of older patients. Prioritize the patient's complaints as you would in triage and start with the most serious and end with the least serious. In terms of anxiety, consider the context of the situation and recognize that the observed anxiety may be a sign of serious underlying medical condition. Frequently, anxious patients can be observed in emergency scenes that involve a large number of patients, such as during a disaster. Some anxious patients show signs of psychological shock, such as pallor, diaphoresis, shortness of breath, numbness of the hands and feet, dizziness or lightheadedness, or loss of consciousness. Anxiety can be an early indicator of low blood glucose level, shock, or hypoxia. With anger and hostility, every patient encounter has a high potential for verbal hostility and physical violence. Friends, family, or bystanders may direct their anger and rage towards you. Remain calm, reassuring, and general. But if the scene is not safe or secured, retreat until it is secured. With intoxication, do not put an intoxicated patient in a position where he or she feels threatened and has no way out. The potential for violence and a physical confrontation is high when a patient is intoxicated. Alcohol dulls a patient's senses, which will make it difficult for an intoxicated patient to inform you that something feels painful. Crying. A patient who's crying may be sad, in pain, or emotionally overwhelmed. Remain calm and be patient, reassuring, and confident, and maintain a soft voice. If you encounter depression, depression is among the leading causes of disability worldwide, and symptoms include sadness, feeling of hopelessness, restlessness, irritability, sleeping and eating disorders, a decreased energy level. And the most effective treatment in handling a patient's depression is being a good listener. Confusing behavioral history. With conditions such as hypoxia, stroke, diabetes, trauma medication use, and other drug use could alter a patient's explanation of events. Hypoxia is the most common cause of confusion. In older patients, it's not uncommon to encounter a patient who has dementia, delirium, or Alzheimer's disease. With limited cognitive abilities, keep your questions simple and limit the use of medical terms. Be alert for partial answers and keep asking questions. In cases of patients with severely limited cognitive function, rely on the presence of family, caregivers, and friends to supply answers to your questions. With cultural challenges, do not use medical language. Patients from some cultures may prefer to speak only with healthcare providers of the same gender. Gain the assistance of the patient's friends or family members and enlist the help of healthcare providers of the same culture or background if possible. With language barriers, find an interpreter if possible. If not, determine whether the patient understands who you are. Keep questions straightforward and brief and use hand gestures. And be aware of the language diversity in your community. With hearing problems, ask questions slowly and clearly. Use the stethoscope to function as a hearing aid for the patient. Learning simple sign language during your career will help in the communication process. And use pencil and paper. With visual impairment, identify yourself verbally when entering the scene. It is important that you put any items that have been moved back into their previous position. During the assessment and history-taking process, explain each step in the vital sign assessment. Notify the patient before preparing to lift the patient and move him or her on a stretcher. With secondary assessment, if the patient is in stable condition and has an isolated complaint, you may choose to perform the secondary assessment at the scene. If the secondary assessment is not performed at the scene, it is performed in the back of the ambulance en route to the hospital. However, there may be situations where you may not have time to perform a secondary assessment. You may have to continue to manage life threats identified during the primary assessment en route to the hospital. The purpose is to perform a systematic physical examination of the patient. The physical examination may be a systematic head-to-toe secondary assessment or an assessment that focuses on a certain area or system of the body, often determined through the chief complaint, which is called a focused assessment. Guidelines on how to and what to assess during a physical examination are inspection, look at the patient for abnormalities, palpation, touch or feel the patient for abnormalities, and auscultation, listen to the body a sound makes by using the stethoscope. The mnemonic DCAP BTLS reminds you of what to look for when inspecting and palpating various body regions. Compare the findings on one side of the body with the other side when possible. Systematically assess the patient in the secondary assessment. The goal is to identify hidden injuries or identify causes that may not have been identified during the 60 to 90-second exam during the primary assessment. This will be worked on in Skill Drill 9-2. A focused assessment is performed on patients who sustained non-significant MOIs or on responsive medical patients. This type of examination is typically based on the chief complaint. The goal of a focused assessment is to focus your attention on the body part or systems affected by the priority problems. With the respiratory system, expose the patient's chest. Look again for signs of airway obstruction as well as trauma to the neck and/or chest. Inspect the chest for symmetry. Listen carefully to breath sounds, noting abnormalities. Measure the respiratory rate, chest rise and fall for tidal volume and effort. Look for retractions and look for increased work and breathing. Assessing the patient's breathing by watching the patient's chest rise and fall, listening to breath sounds with a stethoscope over each lung, and if the patient is unconscious, feeling for air through the nose and mouth and nose during exhalation. When assessing breathing, obtain the following information. The respiratory rate. A normal respiratory rate varies widely in adults and ranges from 12 to 20 breaths per minute. Children can breathe at even faster rates. Respirations are determined by counting the number of breaths in a 30-second period and multiplying times 2. This result equals the number of breaths per minute. With respiratory rhythm, if the time from one peak chest rise to the next is fairly consistent, respirations are considered regular. If the respirations vary or the rate changes frequently, the respirations are considered irregular. You want to check the quality of breathing. So normal breathing is almost silent. Breathing accompanied by other sounds may indicate a significant respiratory problem. The amount of air the patient is exchanging depends on the rate and depth of tidal volume. Tidal volume is a measure of the depth of breathing and the amount of air that is moved into or out of the lungs during one breath. When checking, you can almost hear breath sounds better from the patient's back. The photos on this slide demonstrate how to listen to a patient's breath sounds. What are you listening for? You're listening for normal breath sounds. These are clear and relatively quiet during inspiration and expiration. Snoring breath sounds. These suggest an obstruction or narrowing of the lower airways. Wheezing breath sounds suggest an obstruction of the lower airways. Crackles are wet crackling breath sounds that may indicate fluid in the lungs. Bronchi is congested breath sounds that may suggest the presence of mucus in the lungs. Stridor is often heard before listening with the stethoscope and may indicate that the patient has an airway obstruction in the neck or upper part of the chest. Determine the quality or character of respirations while counting the number of respirations. With the cardiovascular system, you want to look for trauma to the chest and listen for breath sounds. Consider the pulse and respiratory rate and the blood pressure. Pay particular attention to rate, quality, and rhythm. Consider your findings when assessing the skin. Check and compare distal pulses to determine any right and left side differences. And consider auscultation for abnormal heart sounds. With pulse rate, for an adult, the normal resting pulse rate should be between 60 and 100 beats per minute and could be as much as 100 beats per minute in older patients. In pediatric patients, generally the younger the patient, the faster the pulse. To obtain a pulse rate in most patients, you should count the number of pulses felt in a 30-second period and then multiply by 2. A rate that's greater than 100 beats per minute is described as tachycardia. A rate of less than 60 beats per minute is described as bradycardia. With pulse quality, if the pulse feels of normal strength, you should describe it as being strong. You should describe a stronger than normal pulse as bounding. A pulse that is weak and difficult to feel is described as weak or thready. With pulse rhythm, you want to determine whether the rhythm is regular or irregular. The interval between each contraction should be the same and the pulse should occur at a constant regular rhythm. The rhythm is considered irregular if the heart periodically has an early or late beat or if a pulse beat is missed. With blood pressure is the pressure of circulating blood against the walls of the arteries. A decrease in blood pressure may indicate a loss of blood or fluid components, a loss of vascular tone, insufficient arterial constriction, or a cardiac pumping problem. Decreased blood pressure is a late sign of shock and indicates that the critical stage of decompensated shock has begun. Abnormally high blood pressure may result in rupture or other critical damage in the arterial system. Systolic pressure is the increased pressure that is caused along the artery with each contraction or systole of the ventricles and the pulse wave that it produces. Diastolic pressure is the residual pressure that remains in the arteries during the relaxing phase of the heart cycle's diastole when the left ventricle is at rest. A blood pressure cuff with a gauge contains the following components: a wide outer cuff, an inflatable wide bladder sewn into a portion of the cuff, a ball pump with a one-way valve, or a pressure gauge calibrated in millimeters of mercury. Auscultation is the most common means of measuring a patient's blood pressure. and you'll try this in skill drill 9-3. The palpation or feeling method does not depend on your ability to hear sounds and should be used in certain cases to obtain a blood pressure. And you'll practice this in skill drill 9-4. Normal blood pressure. A patient has hypotension when the blood pressure is lower than the normal range and hypertension when the blood pressure is higher than the normal range. With the neurologic system, a neurologic assessment should be performed anytime you're confronted with a patient who has a change in mental status, a possible head injury, stupor, dizziness, drowsiness, or syncope. Evaluate the LOC and orientation to determine the patient's ability to think. Use the AVPU scale if appropriate to determine the patient's mental status. Use the Glasgow Coma Scale or GCS score. That can be helpful in providing additional information on patients with mental status changes. Use parameters that test a patient's eye opening, best verbal response, and best motor response. The pupil is the black center in the portion of the eye. The pupils are normally round and approximately equal size. In the absence of light, the pupils will become fully relaxed and dilated. The diameter and reactivity to the light of the patient's pupils can reflect the status of the brain's perfusion, oxygenation, and condition. This is an example of pupils. You see constricted at the top, dilated at the bottom left, and unequal at the bottom. There is a small number of the population that exhibit unequal pupils. It's called anoscoria. You should assume the patient has altered brain function as a result of central nervous system depression or injury as the pupils react in any of the following ways. If they become fixed with no reaction to changes in light, they dilate with introduction of bright light and constrict when the light is removed, react sluggishly instead of briskly, become unequal in size, or become unequal in size when the bright light is introduced into or removed from one eye. Depressed brain function can be caused by the following: injury of the brain or brain stem, trauma or stroke, brain tumor, inadequate oxygenated or perfusion, or drugs and toxins that affect central nervous system depressants. Pearl is a useful assessment guide. P is for pupils. E, are they equal? A and R, round. And then R, regular in size, and L is react to light. That's Pearl. When assessing neurovascular status, perform a hands-on assessment to determine sensory and motor response. Check for bilateral muscle strength and weakness. Complete a thorough sensory assessment. Test for pain, sensations, and position, and compare distal and proximal sensory and motor responses in one side with the other. And this will be covered in skill drill 9-5. With the anatomic regions, you have the head, neck, and cervical spine. Gently palpate the scalp and skull for any pain, deformity, tenderness, crepitus, and bleeding. Check the patient's eyes and assess pupillary function, shape, and response. Check the color of the sclera. Ask the patient, that's the whites of the eyes, the sclera. Assess the patient's cheekbones or zygomas for possible injury. And check the patient's ear and nose for fluid. Check the upper jaw or maxillae and lower or the mandible jaw. Open the patient's mouth, looking for any broken or missing teeth. Note any unusual odors that may be present in the mouth. Palpate the neck for signs of trauma such as deformities, bumps, swelling, bruising, and bleeding, as well as crackling sound produced by air bubbles under the skin, also known as subcutaneous emphysema. When assessing the chest, you want to inspect, visualize, and palpate over the chest area for injury and signs of trauma, including bruising, tenderness, and swelling. When assessing breathing, watch for both sides of the chest to rise or fall together with normal breathing. Observe for abnormal breathing signs, including retractions or paradoxical motion. Look for trauma to the abdomen and for distension. Palpate the abdomen for tenderness, rigidity, and patient guarding. If the abdomen is broken into 4 quadrants, the left upper quadrant, which is LUQ, left lower quadrant, which is LLQ, right upper quadrant, which is RUQ, and right lower quadrant, which is RLQ. Assess for the presence of rebound tenderness. With the pelvis, you want to inspect the pelvis for symmetry and any obvious signs of injury, bleeding, or deformity. If you feel any movement or crepitus, or if the patient reports pain or tenderness, severe injury may be present. With the extremities, inspect each extremity for symmetry, cuts, bruises, swelling, obvious injuries, and bleeding. Palpate along each extremity for deformities. Check for pulses, motor function, and sensory function. Inspect the back for DCAP, BTLS, symmetry, and open wounds. Carefully palpate the spine from neck to pelvis for tenderness and deformity. Use appropriate monitoring devices, but these should never replace your comprehensive assessment of the patient. Something like pulse oximetry are used to check oxygenation and the effectiveness of it, but it should never replace your comprehensive assessment of the patient. Pulse oximetry measures the oxygen saturation of hemoglobin in the capillary beds. Patients with difficulty breathing should receive oxygen regardless of their pulse oximetry value. When you're assessing vital signs, you want to use capnography, which can quickly provide information on a patient's ventilation, circulation, and metabolism. And blood glucometry measures the level of glucose in the bloodstream. Some non-invasive pressure equipment is the sphygmomanometer, which is a blood pressure cuff and is used to measure blood pressure. With your reassessment, you want to perform at regular intervals and repeat the primary assessment, reassess the vital signs, and compare the baseline vital signs obtained during the primary assessment and look for trends. If the changes in the patient's condition are improved, simply continue whatever treatments you're providing. If the patient's condition deteriorates, prepare to modify treatments as appropriate. Document any changes, whether negative or positive. Reassess the chief complaint. If the patient is an unstable question, it should be reassessed approximately every 5 minutes. A patient in stable condition should be reassessed approximately every 15 minutes. And ask and answer the following questions. Is the current treatment improving the patient's condition? Has an identified problem gotten better? Has an already identified problem gotten worse? And what is the nature of any newly identified problems? Recheck your interventions. Check all interventions, the most important of the patient's ABCs. Ensure management of bleeding and ensure adequacy of other interventions and consider the need for new interventions. Identify and treat changes in the patient's condition. If the changes in the patient's condition are improved, continue what you're providing. But if the condition deteriorates, prepare to modify treatments as appropriate. Document any changes, whether negative or positive, and then reassess the patient. A patient in stable condition should be reassessed approximately every 15 minutes, while a patient in unstable condition should be reassessed approximately every 5 minutes. Okay, class, thank you for your attention in this chapter, and we're going to do some review questions now. Review question 1. During the scene size up, you should routinely determine all the following except A, the mechanism of injury or the nature of illness, B, the ratio of pediatric patients to adult patients, C, whether or not additional resources are needed, or D, if there are any hazards that will jeopardize safety. And the answer is B. The components of the scene size up, after taking standard precautions, including determining if the scene is safe for entry, determining the mechanism of injury or nature of illness, determining the number of patients, and determining if additional resources are needed at the scene. So let's look at the incorrect answers. The question was, during the scene size up, you should routinely determine all of the following except A, the mechanism of entry or nature of illness, but that is part of the scene size up. The ratio of pediatric patients to adult patients, that's the correct answer. C, whether or not additional resources are needed, that is not part of the scene size up. You don't know yet. And if there are any hazards that will jeopardize safety, and this is not part of the scene size up. However, you may discover during the scene size up that there are hazards that might jeopardize safety. You arrive at the scene with an injured person. As you exit the ambulance, you see a man lying on the front porch of his house. He appears to have been shot in the head and is lying in a pool of blood. You should A, immediately assess the patient, B, proceed to the patient with caution, C, quickly assess the scene for a gun, or D, retreat to a safe place and wait for law enforcement to arrive. This one should be obvious. The answer is D. Your primary responsibility as an EMT is to protect yourself. Prior to entering any scene, you must assess for potential dangers. In cases where violence has occurred, you must retreat to a safe place and wait for law enforcement personnel to arrive. So we discussed the correct answer, so it's going to be easy to rule out the incorrect answers. A, immediately assess the patient. Again, you must wait till the scene is safe. B is incorrect where it says proceed to the patient with caution. You must wait till the scene is safe. C, quickly assess the scene for a gun. That's the responsibility of law enforcement, which is why D is the correct answer. You retreat to a safe place and wait for law enforcement to arrive. Question 3. Findings such as inadequate breathing or altered level of consciousness should be identified in the A, primary assessment, B, focused assessment, C, secondary assessment, or D, reassessment. This one should be easy. The answer is A. The purpose of the primary assessment is to identify and manage any life threats to the patient, such as inadequate breathing, altered level of consciousness, or severe hemorrhage. Okay, so let's look at the incorrect answers. A is the primary assessment. That's when you look for and find signs such as altered level of consciousness or inadequate breathing. The focus assessment is something that takes place during the secondary assessment if it's appropriate. That's not the correct answer here. The secondary assessment, and the purpose of the secondary assessment is to perform a systemic physical examination of the patient after the primary assessment. And then D, reassessment. This is incorrect because reassessment is performed to identify and treat changes in a patient's condition after the primary assessment. So any life-threatening injuries are going to be identified in your primary assessment the first time you check them. Number 4, which of the following would you not detect while determining your initial general impression of a patient? A, cyanosis, B, gurgling respirations, C, severe bleeding, or D, rapid heart rate? The answer is D. The initial general impression is what you first notice as you approach the patient, but before physical contact with the patient is made. It's what you see, hear, or smell. A rapid heart rate, tachycardia, would not be detected until you actually perform the entire primary assessment, and you cannot see, hear, or smell tachycardia. You can only feel it. So we just covered all of the wrong answers and why the right answer is the right answer. So I'm not going to review them here. And this is the continuation of it. Number 5. Your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. After protecting her spine and administering oxygen, you should A, reassess your interventions, B, perform a rapid exam, C, transport the patient immediately, or D, perform a focused assessment of her head. The answer is B. If any life-threatening problems are discovered in the primary assessment, they should be addressed immediately. The EMT should then perform a rapid exam to look for other potentially life-threatening injuries or conditions. So the incorrect answers, the question was, your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. After protecting her spine and administering oxygen, you should A, reassess your interventions. This is not the immediate thing you need to do. This is the last step of the patient assessment process. B, perform a rapid exam. That's the correct answer. C, transport the patient immediately. This is determined only after the completion of a rapid exam. And D is perform a focused assessment of her head. And again, this is performed during the secondary assessment. 6, a semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe his level of consciousness as alert, unresponsive, responsive to painful stimuli, or responsive to verbal stimuli. This one should be easy. And it's C. Semi-conscious patients are not alert, nor are they unresponsive. The fact that the patient pushes your hand away when you pinch his earlobe indicates he's responsive to painful stimuli. If he opens his eyes or responds when you speak to him, he will be described as being responsive to verbal stimuli. So the incorrect answer is a semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe his level of consciousness as alert. This is only when the patient's eyes are open spontaneously as you approach. Unresponsive is when the patient does not respond to any stimulus at all, so that's the incorrect answer. C is responsive to painful stimuli. That's the correct answer. And D is responsive to verbal stimuli. This is when the patient's eyes open with verbal stimuli or she tries to respond. But in this specific case, it is C, responsive to painful stimuli. 7. Assessment of an unconscious patient's breathing begins by A, inserting an oral airway, B, manually positioning the head, C, assessing respiratory rate and depth, or D, clearing the mouth with suction as needed. This one should be easy. It's B. You cannot assess or treat an unconscious patient's breathing until the airway is patent, that is, open and free of obstructions. Manually open the patient's airway when you head tilt or chin lift and using the jaw thrust. Use suction as needed to clear the airway of blood or other liquids. Insert an airway adjunct to assist in maintaining airway patency, and then assess the patient's respiratory effort. We covered the incorrect answers in the review of the correct answer, so I'm not going to review the incorrect answers here, and I'm not going to review the incorrect answers here. Number 8. Your 12-year-old patient can speak only 2 or 3 words without pausing to take a breath. He has a serious breathing problem known as A, nasal flaring, or B, 2 to 3 word dyspnea, C, labored breathing, or D, shallowed respirations. This one it's a giveaway, so it should be easy. And the answer is B. 2 to 3 word dyspnea is a severe breathing problem in which a patient can only speak 2 to 3 words at a time without pausing to take a breath. Question 8. Your 12-year-old patient can speak for only 2 or 3 words without pausing to take a breath. He has a serious nasal breathing problem known as nasal flaring or 2 to 3 word dyspnea, and that's the correct answer. C, labored breathing. Labored breathing requires increased effort and is characterized by a depth and effort of each respiration. And D is incorrect because shallow respirations are characterized by little movement of the chest wall or pore excursion. Number 9. How should you determine the pulse in an unresponsive 8-year-old patient? Palpate the radial pulse at the wrist. Palpate the brachial pulse inside the upper arm. Palpate the radial pulse with your thumb, or palpate the carotid pulse in the neck. It's an 8-year-old patient, so that should tell you where to palpate. The answer is D. In an unresponsive patient older than 1 year, you should palpate the carotid pulse in the neck. If you cannot palpate a pulse in an unresponsive patient, then of course you want to begin CPR. 8-year-old patient, if you palpate the radial pulse of the wrist, only palpate here in an unresponsive patient who is older than 1 year. So you can do it at the wrist, but it's more correct to do the carotid pulse. Palpate the brachial pulse inside the upper arm. You only palpate here in children younger than 1 year because the radial and carotid pulses are difficult to locate. C, palpate the radial pulse with your thumb. Do not ever palpate a pulse with your thumb. You may mistake the pulsing of circulation in your own thumb for the patient's pulse. Check the carotid pulse in the neck. That is the correct answer. 10. When assessing your patient's pain, he says it started in his chest but is spread to his legs. This is an example of part of the OPQRST mnemonic. A. Onset, B. Quality, C. Region or radiation, or D. Severity. This one should be easy. The answer is C. The region or radiation section of OPQRST mnemonic assesses a patient's pain, where it hurts, and where the pain has spread. Because the patient informed you that the pain has spread from his chest to his legs, that would be an example of radiation. So let's look at the incorrect answers. When assessing your patient's pain, he says it started in his chest, but it spread to his legs. This is part of an example of the OPQRST mnemonic. A. Onset. This is the assessment of the cause of the pain and when it began. B is quality, which this is the assessment's description. This assesses the patient's description of the pain. So those two are incorrect. C, region or radiation, is the correct answer because it started in one area and it spread. D is severity, and this assesses the severity of the patient's pain, and that's not completely appropriate in this particular example. Okay, class, thank you so much for your time and attention. If you have any issues, please contact your instructor for extra help. And you will perform some of these skills as I suggested when I did the lecture. You will perform the skills and practice these techniques in class. Thank you again, and I'll see you next chapter.